This is She's on Call, a weekly show hosted by ENT specialist Dr. Sajana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sajana Chandrasekhar. I'm an ear surgeon in New York City and New Jersey.
And I'm Dr. Marina Kurian. I'm a minimally invasive surgeon, general surgeon in New York City.
Welcome to our silver show, our 25th show of She's on Call. Woohoo, Marina.
I know. We have a great guest for you this week. I think we always have great guests for everyone. But today's topics are really wonderful on women's health. And we have two amazing experts that we're so excited to introduce to you guys in a little bit. But there are Dr. Janine Bilala. She's the Vice Chair of Gynecology and Chief of GYN Oncology at Lenox Hill Hospital. And she's also an associate professor at the Donald and Barbara Zucker School of Medicine. And then Dr. Mary Jane Minkin, clinical professor of gynecology at Yale University School of Medicine. And we're going to be talking to them about an array of topics.
So first, let us let you know, as Nicole Wallace said in the beginning, we are live on all the social media channels. So please hit share and tag your friends, anyone whom you think might be interested in menopause or menopause or ovarian tumors or cervical cancer or sexuality. Please tag them and have them join us. COVID, Marina.
I know. Hey, so I just read something this morning about COVID, because that's what we do every day. We read about COVID, unfortunately, that in January 20th was the first cases in the US, and it took 100 days to get to 1 million cases, 100 days. And yet this past week, it took 5 days to get another 1 million cases of COVID positive patients, that just shows how fast this virus is spreading. And, there's just the CDC also has some new recommendations, which we're going to get into. But that little tidbit today, that it took 5 days, I just found that was really outrageously bad.
Yeah, I think you had shown me an article showing that hospitals are really at their breaking point. So the hospitals are stretched beyond any reasonable limit. In much of California is actually on a lockdown because there is no capacity left in the hospitals. We're seeing this in Rhode Island. We're seeing this, of course, in the Dakotas, as we've talked about. So even though the vaccine is around the corner, the disease is still here. Today, there was a heart.
Right. The CDC has given us some guidance on who's going to get the vaccine first. That's been, a question. And the feeling is that it will be healthcare workers who are most at risk, along with residents of nursing homes and other long-term care facilities. But I think, I believe they're also looking at, when they say healthcare workers, is it going to be frontline? Because as we know, through this pandemic, there have been a lot of not doctors and nurses, but other people that have been so critical to being a frontline person, even the people at the grocery store. So it's going to be a little bit interesting to see how it'll be delivered. I think that's still a question. Suju, so the other thing is that, the CDC director also said that the schools are not a major coronavirus transmission source, which has been interesting also, that they feel that that I think this is going to mean that the kids are going to be back in school in January, and they're not seeing that the schools are the major risk. But as we know from all the concern around Thanksgiving, that the issue is really going to be that the small gatherings inside your house. And one of the other things that was said, and the CDC just said that this week, is that you should wear a mask inside as well as outside, unless you're in your own home. And quite frankly, I just walked in a little while ago. I had to round today. I'm on call. And so I took my mask off, and then I was sitting here, chatting with Suju before the show started. And I'm like, where's my mask? It's getting to be like such a thing where we have to, put the mask on before we do anything, before we leave. And now when you don't have it on, it feels kind of odd. So let's see. So let's shift gears a little bit, because I want to talk a little bit of the CDC's talking about decreasing the duration of quarantine, which is interesting because originally everyone's like 14 days you have to do, right? And now they're saying, well, maybe you can do 7, maybe you can do 10. And so we've already in New York State kind of pushed this forward to include just 7 to 10 days. So currently in New York State, if you're traveling here from one of the non-designated safe zones, if you will, and you come and you have to quarantine, the idea is that you get a test 3 days before you come here. But once you do the test, you quarantine where you are, come to New York, and then you have to quarantine for 4 days and then get a test. And if that's negative, then you can kind of venture out. But there are other guidelines for making it 10 days in case you can't actually go and get a test, which is, in New York, it's certainly unusual. We get updates all the time about how, we've done 100,000 tests, a day here in New York State, and hopefully around the country. As we see the positivity rates up, it also means that we are testing a lot more, which I think is very good. And I think also we just don't want to let our guard down about relaxing all the things that we're practicing between social distancing, hand washing, mask wearing, and then, relaxing that because we think we're going to get the vaccine. It's so unclear who's going to get the vaccine. And Suju, I already saw a thing about that 80% of doctors in a survey, 80% of doctors said that they're going to get the vaccine. And I'm definitely one of those. Suju and I have already been like, we're going to line up first and get this vaccine. I'll be everyone else's guinea pig so we can see what all the issues are. Right, Suj?
Yeah, sorry, I disappeared in the middle. I think, as soon as they let us take the vaccine, they're going to. I think they're going to stratify healthcare workers by how much in contact they are with potentially contaminated people or potentially infected people. I think they're going to really look at all levels of first line workers, which I think is really important.
Yeah. Well, anyway, we can switch gears. We have some good fun news today, right?
Yes,
you found this. I did not. So go ahead and intro it.
So Time Magazine named its first ever Kid of the Year. And Geetanjali Rao is called a scientist and an inventor. She's 15 years old. And maybe we were kind of smart at 15, but I don't think we were Kid of the Year smart. And she's really looking at artificial intelligence to identify and solve problems of contaminated water, of bullying, a whole plethora of
opioid addiction. I mean, all these things are so great. Yeah. When I was 15, I would be reading, I would read like Time Magazine, or if there was an article on fission, I was like, yeah, I'm going to read that. And I kind of understood it because, I was really good at science, but I was not doing any of this. And so what's really terrible, I'm a bad mom, right? Like I told my son once, there was like some 17-year-old who created this program to analyze articles and create a synopsis. And he ended up selling it to, I believe, Microsoft for like 17 million. And I'm like, Huff, you're like on your computer all the time. Do you see what this kid did? And he was like, that's great, Mom. Way to make me feel bad. I was like, okay, bad mom, poor modeling, poor parent modeling moment. But listen, we're so excited about this show. We want to get in there and discuss it. It's so exciting for us to introduce you to our guest, Dr. Mary Jane Minkin. Again, she's a clinical professor at Yale University School of Medicine, and she's written several books. We're so excited to talk to her about menopause and sexuality, and we're going to talk to both of our guests. Our other guest is Dr. Janine Villella, who's a vice chairman of gynecology, and also she's the chief of GYN oncology at Lenox Hill Hospital. And we're going to talk to her about cervical cancer and as well as ovarian cancer and other topics because they're so interesting. We're so excited to have you guys. Welcome.
Thanks for having us.
So we're going to start with probably we should start talking just about menopause, not because Suju and I are at risk. That is not one.
We are women, therefore we are at risk, my friend.
I mean, it's happened. I'm just saying it's happened for me.
So every time it's too hot in the operating room, I tell my nurse, I'm like, could you please call engineering and tell them I'm either having a hot flash or they have to cut down the temperature in this room. So maybe, Mary Jane, you can help me tell which one that is.
Right. Can I just point out, though, Suju and I must be operating in the same room because I tell them the same thing, and I tell them it's misogyny. And they are being completely disrespectful. It's ageism and misogyny that the temperature is so hot in this room. Engineering hates my phone.
All kidding around aside, though, these issues actually are being attended to these days. There's a significant body of literature coming out to say that because of the large presence of women in the workforce and the large presence of us more mature ladies in the workforce, that we have to pay, that employers should pay attention to things like temperature, availability of windows to open them, or air conditioning adjustment and things like that. And it's actually been shown that if you have menopausal women whose symptoms are not being attended to, it actually costs, money in the workforce. So it's finally being looked at.
That's amazing. But let's talk about menopause and who gets it and what. When we said as women we're all at risk, I mean, it's going to happen, right? So what are some of the numbers and who gets it? Is there an average age? Those kind of things.
Sure. As my standard line is, God willing, we live long enough, we're all going to go through menopause. There's only one way to beat it, and we don't want to do that. Average age of menopause in this country is 51.3 years. That's average. However, if you look at the statistics, and this is where my med students get nervous when I start talking about it, 1% of women will be menopausal by age 40, and 5%, maybe even as high as 8% of women will be menopausal by age 45. So those are youngsters. And it does happen. Now, on the flip side of that, you do see occasional people going through menopause at 59 or 60. So some of my patients are in that category, and they're really mad at me every year. Well, I say, you're not there yet, And the definition of menopause in somebody who has a uterus, i.e. she's getting periods, is that she has to go a year without a period to say she's fully menopausal without another explanation, like being pregnant or something like that. So if she goes a year without a period, you can say, okay, you're done and this is it. However, that many people will say, okay, I've skipped 3 periods, I'm menopausal. And the answer is nope. And what happens is at that point, you still have to reset the clock as far as saying, okay, I have to go that year. But if you go 3 months and have one, well, that resets. You got to go another year at that point to say you're menopausal.
You know what? When we look, we can pop that slide back up, please. I want to show 50 million women in the U.S. currently in menopause. I mean, I know that makes sense, right? Just because of age, but it's outrageous.
Yeah. And the key thing is, and this is another statistic that I love to unload on people. If you look historically in the U.S., the average age of menopause is getting a little higher, possibly because of better nutrition, public health, things like that too. The average age of menopause in the United States in the year 1900 was 48. Now it's 51. Okay. The average female life expectancy, if you look at statistics in the year 1900, was also 48. Whereas now, thank goodness, we're dealing with a life expectancy into the 80s. So that indeed, my standard line about 1900, well, you're supposed to go through menopause and die. That was it. Have a nice day. You're done. And so now we have to deal with a lot of our valuable lives, we hope, are postmenopausal, and we want to make them happy and healthy and productive. That's the way I look at it.
Right. So the thing, and Sujit, feel free to jump in. But the thing about the 50 million and the fact that you started this conversation off saying that, the workforce is finally looking into this. I mean, that's the outrageous thing.
Yeah, no, it's there finally. So we're getting there. And unfortunately, there's still a lot of stuff. Well, fortunately or unfortunately, there's a lot of stuff to investigate and discover. For example, we don't really fully understand why and how hot flashes occur. I mean, that's the, arch symptom that women in this country talk about. But we really, at this point, still cannot tell you. I can't tell somebody why she's getting a hot flash and how long it's going to last and things like that. It's just not known yet.
So, Mary Jane, can you explain what's the difference between perimenopause and menopause? And is it something that we should be afraid of? Is it something we should embrace? Like, I don't even know how to react, and there are some of us who have very few symptoms and some of us who are just debilitated by our symptoms.
It's all over the place, okay? And first of all, this is nothing that anybody should be afraid of. Please do not be afraid, because there's something that we can do for everybody. It's really, it's not that we don't have any solutions for people. Perimenopause is the time leading up to menopause, okay? And that's when you may start getting some symptoms, okay, as far as hot flashes, night sweats, sleep issues, whatever, but you're still getting your periods. Until you go that magic full year without a period, you're still perimenopausal. Now, the exciting news, is you can get hot flashes and stuff even before you skip one period, so that these symptoms can occur fairly early. The hot flashes, night sweats, sleep issues tend to occur early, whereas things like the fun-filled vaginal dryness, bladder symptoms, and things like that, nice graphic there, thank you, that those things tend to be more as we get further on into the menopausal continuum here. So, an example, for some women, dry vaginas don't even occur until they're 4 or 5 years out, and they don't even associate the dryness with menopause. It's like, oh, what's going on? I'm getting dry vagina. Okay, well, that's probably menopausal, but they don't even think about it because they associate hot flashes with menopause. And so you're right, because indeed that about 20% of women get no hot flashes. 20% get severe hot flashes, really debilitating. They break into a sweat. They have to stop dead in their tracks to attend to the hot flash. The other 60% of us are sort of in the middle. They get some hot flashes, but they're not totally debilitating. So that's sort of the variation. And the other really interesting, well, there's many interesting things. Can I make a plug?
Yeah.
For anybody who's really excited by this topic, please go to my exciting website, madameovary.com. French spelling, MADAMEOVARY.com. And you can learn all this stuff there. Fabulous videos, podcasts, wonderful articles, all written by me. But anyway.
I have to say, I went there yesterday and I loved it. I went to medical school. I'm pretty sure I stayed awake, but I learned so much from the videos and the podcast. So thank you. And it's really approachable information.
Thank you.
Thank you.
So if you guys are excited about this, please go to the site to learn more. So anyway, a couple of the things though about hot flashes, which I think are really cool. Anyway, that although we have hot flashes as the number one complaint in the United States for women in menopause, actually, it's not a universal symptom that everybody's got to get. For example, in the Philippines, I had the privilege of meeting the president of the Philippine Menopause Society a few years ago. And she told me that indeed in the Philippines, the number one complaint that women get is achiness, a body ache, sort of like muscle aches, joint aches, things like that, which is their number one complaint. Hot flashes are way down on the list. Now, what's also interesting, at least to me, is the fact that if you look even in the U.S., that different populations tend to share more of the burden than others. So, for example, African-American women seem to have worse hot flashes, say, compared to Caucasian women, and that Asian women seem to have less of a burden of hot flashes. Do we know why? No. There's another Nobel Prize there. We just don't know the answer. But it's interesting.
It is. There's so many symptoms of menopause, but like as kind of a joke, there's actually a menopause as well. So if we could, the Time magazine put this up, and but it's not a joke. There are actually things that have, like, we call it menopause, but it can be andropause, and we're not going to talk about it today. But we just wanted to let our viewers know that we feel you. I mean, menopause is definitely worse than menopause, I think, but there is an andropause that can actually give a lot of symptoms.
Well, sure, and indeed, one of the reasons that there's a difference is that if you look at hormone secretion, that with men, their testosterone levels definitely go down over the course of time, but it's very gradual. Whereas in women, it's a much more abrupt change. That although there's this perimenopausal transition time, in general, it's going to be 2, 3, 4 years. Whereas in men, it's just a very, very, very gradual decline in the levels. Whereas we go down to a very low level of estradiol over very few years.
Right. So just go ahead, Suju.
Yeah. So, I agree. I think that we're talking about these different changes as we age, and it's really important that we be prepared for it and not be afraid of it. I think people get very frightened of maybe they knew somebody who had a terrible menopause, or they know a man who is really going, really responding to low T very poorly. I just want to remind everybody, we are live on all the social media channels. So please share and like and tune in and tag your friends who might be interested in this very important subject of women's health today. We're going to switch a little bit, and every woman, hopefully, will undergo menopause, but some women will have other terrible things that happen that can be treated. So, Janine Villela, we are so excited to have you here. You have a lot of clinical and research experience with ovarian cancer. So maybe you can talk to us about that, about what we should be looking for and what's on the horizon.
Okay, well, thank you. Thank you so much for having me. And I really enjoyed listening to Dr. Minkin. A lot of food for thought there. And it's nice to know that we are all supported in menopause. We have to support each other through it. Ovarian cancer is a cancer that affects women. There's about 22,000 cases per year in the United States. Unfortunately, is a very serious death rate to this. It's about 50% of patients die within 5 years. And it's really one of the most common cause of cancer death in the United States. We used to think that there was it was a silent killer, and that was sort of the name of it. But in fact, we know that it's not. There are symptoms of menopause. When looking back, there was a study of retrospectively looked at women who had ovarian cancer and found that indeed they did have side effect symptoms. And those were bloating, early satiety or difficulty eating or feeling full quickly, urinary urgency or frequency, pelvic and abdominal pain, or the feeling of the belly getting more distended or swollen, or quote unquote, they thought they were gaining weight, but in fact, they were actually trying to lose weight. So these symptoms that occur for 2 weeks really need to be investigated by a doctor, and they also those physicians should include a gynecologic oncologist.
So when you have these symptoms, is it that there's a much larger ovary, or that it has spread, or can you see it with, the ovary is a kind of a small organ, right? So
correct.
Can you see it with just an early ovarian cancer? Can you see these symptoms of feeling full or bloated with that?
Yes, you can. So early ovarian cancer, which stage 1 and stage 2, which is about 25% of patients present in those stages. And usually those patients have disease confined to the ovary or the pelvis. So you might feel mostly bladder symptoms, pressure, dyspareunia, which is painful sex, constipation. And then when the cancer starts getting more advanced or moving out of the pelvis to the upper abdomen and filling up with that water called ascites, cancer cells, that's when they have those more pronounced feelings of early satiety. So yes, they can be seen in all stages. Most cancers, unfortunately, which leads to the worst mortality, is that 75% of patients are diagnosed in stage 3 and stage 4.
So can you explain the slide?
Yeah, let's look at the slide and talk about, unfortunately, you want that. Listen, Madam Ovary, I wanted this ovary to look like beautiful, but this is actually kind of like what they look like inside, the one on the left of your screen. But Janine?
Yeah. Yes. So I think, normally ovaries are pretty small. When you're younger, they're sort of big, maybe like the size of an apricot or so. But when you get older, they can shrink down, in menopause to like a size of I hate to say this, like a chewed up piece of chewing gum. I mean, they could get quite small. So, and they're actually floating in the abdomen. So I always think, like, if you think of like your arms out and you're kind of dangling little, balls from your hands, that's like how the ovaries are. And so they're free floating, but then they get heavy when tumor starts to happen, and they can attach to other organs. And that's really where you start feeling the symptoms. But they're very nonspecific. And unfortunately, most women are constipated. Many women are too busy to even focus on themselves because they're running, taking care of everyone else. So by the time they actually, think about these symptoms, it's been more than 2 weeks.
Let's talk a little bit about diagnosis. Like, say you're like, okay, I go into my regular GYN for a checkup, or your primary care who's probably going to send you to the GYN. Yeah. What then is the workup for that?
So usually, unfortunately, most people don't get to the gynecologist until it's a little too late. It takes, on average, about a month to 6 weeks. They usually start with the internist, then they get sent for a colonoscopy, upper GI, then they have a CAT scan, which shows, unfortunately, the mass, and then they go to the gynecologist. And unfortunately, that's sort of what happens. So the diagnosis is kind of delayed. But really what should happen is you should have a physical exam, because physical exam is important, which includes a vaginal exam, and a rectovaginal exam, because that's the only way you can feel the posterior surface of the uterus. And in an area called the rectovaginal space, which unfortunately is where a lot of tumors reside. That's the first thing you should have. The second thing is imaging. Transvaginal ultrasound remains the best imaging modality for organs, for GYN organs. But usually then you'll have a CAT scan and then tumor markers called the CA-125, which is a test of the serum that many people have heard of. And usually we get other tumor markers like a CA-19-9, a CA-27-29 to rule out other causes of cancer.
Right. So those are all blood tests that you're drawing. So like if you were to see, the thing is you're GYN oncology, and we definitely want to get into that because that's different than just GYN, not just GYN. GYN covers a lot. But you're getting an ultrasound, then you're getting this blood work, and also you have to get the CAT scan as well. Right?
Mm-hmm. Yes. Very important.
Yeah. And so those are just blood tests. The CA-125 you said, and then CA-19-9, and there's so many. And you're right, there are 4 different cancers as well, but there's also some overlap between the cancers.
Correct. And that's why we don't, tumor markers, a lot of people want the CA-125 done, but you have to understand it's a very non-specific test. In fact, only 50% of patients with early stage ovarian cancer and 80% of advanced stage cancers have an elevated CA-125. So it's a test that we like to know the results if you have cancer. So if we're very suspicious that you have a cancer, we will get the test, but it doesn't really, unfortunately or fortunately, it doesn't really change management. We go by clinical impression, really.
Can we talk a little bit about what the surgery is that you do? And obviously it depends on the stage, which if we could break that down.
Yeah.
And then I do want to talk about a little bit, have you talk about tumor debulking, because we'll get into that at the end, but I that was something that we, as a general surgeon, I was always like, what are you guys doing? That doesn't make any sense, but it totally makes sense. Yeah. And when you have tumor that's not like, I'm jumping the gun. Let's start with just like, you see somebody, you have something that they think, that you think you can take out, and is it curative? Is it not curative? That kind of thing.
Okay. So the first approach is, if our impression is that someone has cancer, to determine if we think it's spread, and obviously. So if we just have a scan that shows just an ovarian mass, and that mass turns out to be malignant, usually what we do a lot of this minimally invasively, and we'll take the mass out, which means we'll take the ovary and tube out because that comes out in one piece, and we'll send it to the pathologist. If the pathologist says at that time that there's a malignancy, then we do what we call a staging procedure. And a staging procedure is when we do biopsies of areas where the tumor could spread to. So for instance, pelvic lymph nodes, para-aortic lymph nodes, and a fat pad in the abdomen called the omentum, and some biopsies of the diaphragm, or the peritoneal lining, which is the lining that actually lines the whole peritoneal cavity. So that's called a staging procedure. And that's a very important procedure because about 30% of patients will be upstaged, which means that if you think there's someone's a stage 1, after you do all those biopsies, you'll actually find out that they could be a stage 3, which actually changes their prognosis and actually the treatment. If we look at the scan,
can I ask you something, Janine?
Yeah, sure.
When you're doing those biopsies, are you seeing an abnormality, or are you just doing what in ENT we call directed biopsies? So we see a mass somewhere and we know the places where there could be hidden cancer, so we're biopsying what kind of looks normal.
Correct.
So are you biopsying while you're, the frozen sections come back, it looks like cancer, so now you're doing biopsies of things that kind of look normal to you, but you know that that's where the tumor is going to go, if it's going to go?
Right. If cancer is going to spread, this is the modality. It spreads by lymphatic and in the peritoneal lining. So those are the areas that we check. Exactly.
We have a question, Janine. If you could look at the screen. Miriam Berkeley's asking, and we do love our viewers really have wonderful questions. And she's asking if women who have not had children are more or less at risk for ovarian cancer.
Yes. In fact, people that have infertility are more at increased risk. Endometriosis. So if you look at the general population, your lifetime risk of developing ovarian cancer is about 1.6%. If you have endometriosis, and that's often associated with nulliparity and infertility, you have a 50% increase. So that means you went from 1.6 to 2.4% chance of getting cancer. So it's still quite low. In the general population, your risk is about 1 in 75 for getting, or 70 or 75 for getting ovarian cancer. And yes, we do think that nulliparity or having no children increases your risk for ovarian cancer because you're having more ovulation. So anything that causes more ovulation, which is disruption of the lining of the ovary, will increase your risk for ovarian cancer.
So, there's something that especially teenagers who are starting their periods experience, and it's called Mittelschmerz, which is one of my favorite words from medical school. But do you think you can tell our audience what that is, and should people be concerned about that?
I think that would be a good question for Dr. Minkin.
Yeah,
right.
It's fine.
Okay, Mary Jane.
Dr. Minkin, this is
the Germans have good words for everything.
They really do.
It just means good pain is what it is. And it's basically the pain when you ovulate. Okay. And when young women start having their periods, oftentimes they're what we call anovulatory cycles. They're not ovulating yet. It takes them a couple of years to really start ovulating well. And then they'll be more aware of this discomfort. And when you ovulate, you are actually popping a cyst from the ovary. The area around the egg becomes filled with fluid, and you're actually rupturing a little cyst every time you ovulate. So that indeed that can even give you a little blood in the belly. It can be very painful. So there are, some people who have significant pain. And of course, one way that we can take care of Mittelschmerz very easily, as long as you're not interested in getting pregnant, we can put you on birth control pills. And the other nice thing, for these patients is that to try to keep business from having business in the ovarian cancer business, that birth control pills actually also significantly reduce the risk of ovarian cancer. So that women who take birth control pills, I don't know, are you guys quoting a level of 30% or 50% these days on reduction of ovarian cancer on that, Janine?
Okay, Mary Jane, exactly. That's a very good point. Ovarian cancer risk reduction has to do with what we call chemoprevention in high-risk patients, is to decrease the risk of ovulation. So that's birth control pills. And we know that the longer you're on a birth control pill, the better it is. So if you're on a birth control pill for 6 years, your risk of ovarian cancer is decreased by 50% for the next 10 years. So that's a significant amount of risk reduction. And that's one of the best strategies we have to decrease ovarian cancer risk.
Yeah, and the other thing that also people may want to know about, because I'll bet Janine's going to get into this shortly, is our issues with people who have the BRCA gene. And even in women who have the BRCA gene, birth control pills help. So if somebody's not yet ready to have, I'm sure Janine's going to talk about taking out ovaries prophylactically, that if she's not ready to do that, birth control pills can be helpful for those folks too.
Yeah. You know what? Can we just talk about BRCA, what that is? Some of our listeners may not be aware, but I think.
Yeah, sure.
Let's
So everybody has a BRCA gene. A BRCA gene is a tumor suppressor gene. There's two types. There's BRCA1 and BRCA2. And some people inherit from their family members, which we call germline or hereditary mutations in this gene that doesn't allow it to be a tumor suppressor or a prevention of cancer gene. So what happens is that these patients are at increased risk for developing cancer throughout their lifetime. And actually, it also, you might hear that their family history, they have multiple family members that have early onset cancers. So, the average age for ovarian cancer is over 60, about 61. If you have a BRCA1 mutation, it's actually 51. And if you have a BRCA2 mutation, it is still 61. And I just told you before that the general risk of the population of getting ovarian cancer is about 1.9%. 1.6%. If you have a BRCA1 gene, you have about a 40% chance of getting ovarian cancer and about 20% chance if you have a BRCA2 mutation. So it's significantly higher. And these are the patients that we're looking for risk reduction strategies.
So I'm going to switch gears a little bit. First of all, I'm going to remind our viewers that we are on all the social media channels. We love your questions and your comments. And I know Marina and I are just like, where's the popcorn? We're just going to watch these two women talk to each other.
I love that. And we ask each other questions. So that's why I was smiling. So I was like, this is great.
We could just sit back and kind of have our pipe or something. But and Janet Weeks is saying, this is great info. This is in fact great info. Susan Japone is saying, great topics. Thank you. We're really having a lot of people. Margaret Ambrosino from Brooklyn is listening in. So we're very excited to have you guys with us. One of the things we talk about is sexuality, and I think sexuality at various stages. And I want to say that I'm very excited because I think talking to Mary Jane is possibly the closest I'll ever get to talking to Dr. Ruth Westheimer. And Dr. Ruth, for our younger viewers may not know, really separated shame and fear from talking about sexuality to general populations. I remember seeing her on Sesame Street and Phil Donahue, and really talking about sexuality at various stages, including during and after menopause. So maybe Mary Jane, you can talk. Mary Jane and Dr. Ruth went on a speaking tour, a book tour in 2005, and the Case for Sex Beyond 50 is the article that appeared in the Chicago Tribune at their appearance at a bookstore there. So I wonder if you can talk to us. You've written a number of books, Mary Jane, about this topic and what people, men and women, should expect.
Well, can I take the rest of the show? No. Anyway, let's just talk a little bit about the comments on that article said sex after 50. When Dr. Ruth and I were talking to mostly, lay audiences, a couple of guys, mostly women, about these issues on sexuality. And Dr. Ruth, she was, of course, the sex therapist, and I was, of course, the gynecologist. And Dr. Ruth would get up the first lecture or two that we were giving and say, I think people should be able to have sex till they're 99. And I would follow that. The first time I heard that, I said, Dr. Ruth, why are you cutting it off then? You're right, 100. So yes, there is no stopping when you should be able to have sex. One of the problems is, and I alluded to this a little bit earlier, is unfortunately with this darn menopause business that our estrogen levels go down and our vaginal tissue can get dry. And that happens to most women. So it's not that you're abnormal. If it happens to you, it's normal. But the good news is we can take care of it. There is no reason that any woman should be suffering from, and all of our listeners, please, there is no reason you should be suffering from a dry vagina. There are a lot of therapies, and you see that beautiful, I have to make a comment on this beautiful slide, which is one of my favorites. And you see in the premenopausal woman that there are a lot of folds in the vagina. You can see that, and there's a muscular coat where, and then the postmenopausal women where there's loss of the folds. So one of the great women in our field is a woman named Raquel Arias out in California. And I will steal her line all the time to say, isn't it terrible that nature takes away the wrinkles wrinkles where we really want to have wrinkles and put some where they shouldn't be. So anyway, so it's a stolen quote from her, but it's great. But the key thing is we can fix this. There are a lot of over-the-counter things that one can do. There are moisturizers, which are available over-the-counter, non-hormonal, no prescription, that you can insert in the vagina 2 to 3 times a week. Okay. And then, of course, there are lubricants, many lubricants that can be used at the time of sex. So we've got that. That's easy to do. If that is not sufficient, we have some really wonderful vaginal products, mostly estrogen. There's one that's DHEA. And there's actually an oral medication, which is not estrogen, which works very nicely. But these are all prescription remedies, but that are really excellent at making the vagina moist. So we should be able to make sex totally comfortable for people. It really shouldn't be a problem. And the other good news about vaginal estrogens is the amount that's absorbed of estrogen into the bloodstream is so low that actually most women who've had a history of breast cancer can safely use it. We have actually statements on that from both the American College of OBGYNs and the North American Menopause Society. So there are nice statements showing the statistics so that just about everybody should be able to use vaginal estrogen and should be comfortable with sex. Now, so we can fix that part. Now, there is a different issue out there, which is called libido, which is sex drive. And we can, and again, many women will say to me, oh, my sex drive's off. And I'll say to them, well, how's your vagina? I walk into a room and say, how's your vagina all the time? And they'll say, oh, my vagina is very dry. And I'll say, does it hurt? Yeah, it hurts. And I'll say, well, let's fix that first. That's not the problem, they tell me. About 50% of the time, actually, it is. Because I always say, why do you want to have sex if it hurts? I've got to fix it for nothing else so that you'll be comfortable. That's important. So, it may take us 2 to 3 months to get everybody a perfect vagina, but we can do it. And so the key thing is that if libido is an issue, we got to take away the pain. There are plenty of women, though, who we've taken away the pain. They're totally comfortable, and they're still not interested in having sex. And for those folks, we have a lot of different options. One is, of course, for Dr. Ruth, how about talking to your partner? And again, Dr. Ruth's lines used to be when I have to do the whole speech. Then the husband comes home, and he just got the blue pill. And he says, hey, honey, come over here. And he hasn't, the best part is the best. And he hasn't taken the garbage out in 4 days. And he hasn't talked to her since the Super Bowl. Well, what do you think she's going to do? And so that's Dr. Ruth's speech on the topic. So libido. So, he has to take out the garbage and he should talk to her instead of listening, not watching the Super Bowl there. So anyway, that communication is important, a lot of other social issues, privacy, things like that. But there are some medical interventions that we can do. For example, a hormone like testosterone, which women also make. Many women are not aware of this, but testosterone is made by the ovaries, less levels than estrogen, but still there. And that sometimes replacement of testosterone can be very helpful. So we got lots of options out there.
We have a question about a procedure called Mona Lisa.
Mm-hmm. Well, this Mona Lisa and there are a whole bunch of other procedures out there which are based on laser, different kinds of laser therapy, different heat energy things. And it's sort of a counterintuitive thought. Why does something that destroys tissue make for more moisture? But supposedly you get stimulation of collagen production by this laser business. The problem that we have with it is that it's not covered by insurance. And part of the reason it's not covered by insurance is we don't have prospective randomized trials comparing different methods and safety issues. There are some safety issues. This is laser, of course. So that it's expensive, not covered by insurance, usually is not a permanent solution. It's not like say, okay, we'll get the laser and I'll be fine for the rest of my life. No, most of the time you have to repeat it in a year and a half, something like that. But it's another option out there, but there really isn't a lot of data yet on prospective randomized trials. So both the North American Menopause Society and the American College of OBGYN say, let's get those studies done so we can investigate it a little better and then get it officially approved.
Janine, I want to ask you, because you're going in and you're messing around with the women parts, and that can affect women's libido or their feeling of being a woman, right? So yes. Let's just talk about sexuality after cancer surgery.
So I see, women every day, and this, I think in my office, this is the number one struggle. Many people, women namely, feel that they failed themselves if they have cancer. If they got cancer in the uterus or the ovary, or the cervix, I didn't follow up with my doctor. It's all of a sudden I shouldn't have had an abortion. I should have taken the birth control pill. I'm overweight. So it's immediately a guilt producing scenario for them. And then having to have the surgery, a lot of women sort of block out below the belly button, it seems, or beyond the bikini, they kind of don't think about it. And so they really retreat into their own sort of, I would say, guilt about having a cancer, and blaming of themselves. And also they feel less than with their partner. And it's a very hard thing for women and men to discuss. And I think really I encourage women to do one thing that's very important. And I think it's something that it should not be so taboo to discuss. I think masturbation is very important. Women have to start feeling comfortable with themselves and try out things on themselves before they are with their partner again, if they have that kind of an issue. Or of course, I think Dr. Ruth is right. Speak to your partner is most important. But I think women are afraid, and oftentimes there's pain associated with, sexual activity after. But you have to remember, there's not only intercourse, there's other things like intimacy that's very important, and really establishing those guidelines and establishing those relationships as soon as possible is very important.
I really appreciate both of you saying that, because I think these are, it's 2020. You would think that we would have been able to talk about things, but really we are so uncomfortable within our bodies still. I want to again say lots of viewers on social media, lots of great comments about how terrific both of you are. You had mentioned, Janine, endometriosis before, and I think that's something that afflicts a lot of women. And maybe you can talk to us a bit about what that is, and then what problems it can cause, and then of course what someone like you or Mary Jane can do about it. So, Janine.
I think really endometriosis is where there's ectopic, which means tissue that's in a place where it shouldn't be. So in other words, you have endometrial glands in other places, such as the ovaries, the fallopian tubes, the pelvis, the bladder, the bowel. And what we think happens is that there's like a retrograde, which is a backwards flow of menstruation. That's one of the thought processes of how this occurs. And it causes severe pain because, as you can imagine, every month when you bleed from your uterine lining, you'll also be bleeding where all of this ectopic tissue is, the endometrial tissue that's in other places. So that all gets swollen. So normally you just have a menstrual period from your uterus on your endometrium, which is the inside lining of the uterus. But if you have endometriosis, you're also having that kind of bleeding everywhere in those areas. So there's a lot of pain, there's scarring because that blood is caustic to the tissue in the peritoneal cavity, and it can cause severe pain and infertility because it can block the tubes, and fatigue, and really some very significant symptoms.
So do we go to see you if our periods are particularly painful? Like, how does a woman even approach this as a thing? Like,
Mary,
everyone's really uncomfortable at their period, right?
I think really if women have severe pain, they should go to a gynecologist. I'm an oncologist, but someone like Mary Jane would be a great start. And really not be afraid to talk about painful periods and heavy bleeding. It's something that needs to be addressed, as it causes a lot of impact on women's life and their ability to work and function in society.
And then what treatments are there, Mary Jane?
We got a lot of treatments out there. And indeed, this has gone back and forth in OBGYN. Do we treat or do we diagnose first? And I think we're more in the school of treating these days because some of the treatments are really easy. Let's get back to birth control pills because they're quite effective for a lot of things. And they're one of the treatments for endometriosis. So that indeed, if you have a young woman who comes in who's having terribly painful periods, examine her, you don't feel any masses, which is the typical thing. You occasionally feel some masses in endometriosis, but not usually. And you say, hey, you want contraception? Well, why don't we try some birth control pills? Let's see if we can help with two things. Let's take care of your contraceptive issues for you, and let's, see if we can help your endometriosis, presuming you might have endometriosis, see if we can help that. So that's quite effective. Where many people will get into the issue of, well, if that doesn't work, then where do you go? Okay. And then we have several other fancier therapies for endometriosis, including basically shutting down the ovaries, things like menopause in a jar, shutting down ovulation. There are a lot of different techniques that we can use. There are also some people at that point that would say, well, let's take a look in the belly, because unfortunately, ultrasounds and MRIs are not the be-all and end-all as far as diagnosing endometriosis, because you can have little tiny implants of it without any big blobs of it. So that some people will do a laparoscopy, take a look inside, and then if they see endometriosis, actually destroy it while you're looking at it. You can blast it with those things like laser or electricity, things like that can actually, destroy the endometriotic implants themselves. So that's an option. But many people will just start, beautiful photo there. Very nice, very nice. Of endometriosis sticking itself, and it can, as Janine said, stick itself around the bladder. It can stick itself around the gynecological organs, the bladder, the bowel, all those fabulous places in our bellies. And again,
so Mary Jane, just to explain the graphic a little bit, those spider webs that we see coming forward and backwards and up, that's all the inflammation from the endometriosis, right?
It's inflammation, and that makes a little scar tissue, and you can actually during laparoscopy cut that stuff. And so that we can make the organs move more freely, which can be very, very comfortable. So it's a good technique. So if somebody's really uncomfortable, and particularly if she flunks, the other thing that I should mention is there are medications that I think most people are familiar with called NSAIDs, and non-steroidal anti-inflammatories. And so if you don't have stomach problems or things like that, and you can take things like ibuprofen or naproxen, things like Aleve, Motrin, those can be very helpful. And if your pain goes away with Aleve or Motrin, something like that, you probably, are good keeping on it. But if it's, you're taking birth control pills, you're trying Aleve, you're trying Motrin, you're still pretty miserable, you definitely want to be seeing a gynecologist to say, are we cooking endometriosis and how do we deal with it?
Yeah, that's wonderful. I mean, it's the treatments and the surgeries, but it's really about finding that endometriosis, right? Like it's so eye-opening for women sometimes when they realize, like, I've been suffering, right? Like you only know your own pain. You only know your own menstrual cycle. You don't know what it's like for other people. So isn't that a common thing to hear? Like, I didn't know I was having heavy periods. It's just what I was used to. Like, you just don't know. But and then when you're having the pain, you're like, yeah, we all have. What do we say? We all have pain. My daughter told me, like, that her ovaries were at war with her body. And I was like, dude, that's dramatic. And then I started thinking, I'm like, you know what? Don't say that. Like, it's probably, she's really, and, it was in so much pain that, it was something that I had her address with her GYN. So, we tend to minimize because we have every month for years until you don't, right? But it really is still an issue. I want to switch gears a little bit, though. I want to talk to us, like, your GYN, Janine, your GYN oncology. Can you explain, you guys just explain to us the difference, and also just how you got where you are, because you're both, leaders in your field. You're mentors to so many and looked up to by your fangirls right here. So
Thank you.
So, yeah, I think maybe Janine is also considered a key opinion leader in GYN oncology. And I have to say that women, even in OBGYN, are often not considered for key opinion leader roles or KOL roles. So maybe you can talk to our audience. We have medical students who watch, we have residents who watch, we have physicians who watch, we have people who are not at all involved in healthcare except as patients watching. But maybe, Janine, talk to us about your journey to where you are.
Well, I will tell you that I think how my journey really started was I never took no for an answer, and I just always thought I can do it. If someone else can do it, I can do it too. And, you know, when I first applied for GYN Oncology Fellowship, I actually didn't match. There was only 17 spots in the country. I had already done 4 years of residency and I didn't match. I took a 2-year fellowship at Columbia, which was basically a fellow, but I wasn't really in a track where I could get board certified. So I thought to myself, I was always interested in research. So I just I walked into the labs at Columbia and I said, I need a research project and I'm interested in ovarian cancer. And there was a really nice PhD who let me, you know, kind of play around in the lab, and it became my passion. I worked tirelessly, and then I got a fellowship for board certification at Roswell Park Cancer Institute, and I continued just to push in a very male-dominated field, as many of us, I think, especially Jane and Sue and Marina, I just kept pushing and doing and being happy. I think the most important thing is I knew I loved GYN oncology, and I was very lucky to have good mentorship in basic science, immunology research, who Dr. Kunle Odunsi is at Roswell Park Cancer Institute. He's still my mentor. He was from Nigeria, and he became one of the best and most powerful immunologists in cancer immunology for ovarian cancer in the country and in the world, actually. And then I just continued to grow my practice, clinical trials, and publications. It's really because I love what I do, and I've been very fortunate to work with fabulous colleagues like all of you that have helped support me. And it's really been a passion.
Mary Jane?
Well, there's 1 degree of separation in the whole world. Kunle's one of my old residents, so I was going to ask how Kunle doing.
He's from Yale.
Fabulous. So anyway, no, my problem was I still haven't grown up, so I don't know what I want to be when I grow up yet, but I'll find it out. So when I finished my residency in OBGYN, I really had no idea what I wanted to do as far as subspecialty. I liked everything. I liked delivering babies. I like doing cancer surgery. I like giving people hormones. So I said, okay, fine. So fortunately, I was able to do a general practice. But the nice thing about being at Yale, practicing in New Haven, you could do a lot of teaching. And actually, the bulk of our teaching is done by our private community. So I was basically very closely linked to the university in the medical school as far as teaching. And in my early days, in my youth, I did a lot of obstetrics. But what happened is my patients got older as I got older. And what was happening at that point is my patients were beginning to be menopausal, and there wasn't a lot of, certainly not disseminated information, not a lot of research on it. So I started focusing on the menopause because my patients were there. And now, I mean, I still I don't deliver babies anymore. I still like dealing with obstetrical issues, but I don't deliver the babies. But I still am interested in it. You know, I like to go to rounds and yell at my residents just like I always did. So.
I want to put up one of your books. You've written 7 books, is that right, Mary Jane?
Something like that, yeah.
Yeah. So these are some of the books, and I encourage you guys to go to madameovary.com. First of all, did you break the internet when you took that website? Like, how cool is that?
Yeah, that's amazing.
You know, it's funny. My husband reserved that name many, many years before we actually did the website, because his thought was basically, what do you call a gynecologist who was a French minor in college? So that's me. So anyway, that's how we got the name, and we just never developed the website till about 4 or 5 years ago. So now, and the other exciting thing to push the website, folks, I came into the 21st century finally, because I now have podcasts on there.
Very exciting. You
Great.
also are responsible for the women's health part of Prevention Magazine. So I think all of us being able to communicate to people these very complex ideas in ways that can be understood and processed is really it's really an amazing gift that we have to share with people. Miriam Berkeley says, especially useful today. Great guests, of course. We are just about out of time, so we want to thank you so much Janine Villela, who is the chair of GYN Oncology at Lenox Hill Hospital, and Dr. Mary J. Minkin, who is obstetrician gynecologist at Yale New Haven. Thank you so much for being with us today.
Thank you.
Thank you.
Honestly, we may have to just bring the team back.
Yes.
Just for another episode. So
there's so much we didn't get to, right?
So don't block our emails, okay, because we'll tweet at you too. So you'll have to come back and join us.
Thank you.
Thank you. So
My pleasure. Thank you.
Thank you, guys. And we couldn't do this without our great production team. We have Sri Srinivasan, who's our executive producer, but Rose Horowitz, Vandana Mann, and Julia Weeks is our producers. Our video highlights, if you see them on Twitter, are from Keval Ramanathan, and our design director is Shrishti Hebar, and voiceover, again, is Nicole Lewis. So we want to thank all of them. And stay tuned. Next week, you guys, we're going to be back. We have some new guests next week, and we're going to be talking to Rachel Lustgarten, and she's a dietitian who does the radio show with me on Dr. Radio. She's my co-host. And also we're going to talk to Dr. Joanna Maragaya, who's an endocrinologist, and we're going to touch base on diabetes and nutrition.
Thank you all for watching. Stay safe and keep wearing a mask.
Yep. We'll see you next week.